Good afternoon, everyone. My name is Nicole Christensen from Care Answered. I'm the CEO here, and I'm very excited to have this panel discussion in regard to Medicare. And we have great panelists that I'll introduce in just a few moments, but I'm so glad that you're here. There's a lot of things to discuss, and we want to get right to it. So again, my name is Nicole Christensen. I'm the CEO of Care Answered, and I'm also the author of the book From Crisis to Calm. At Care Answered, we help to navigate people through the healthcare system during their most challenging times. We get healthcare done. And I also started a new venture, which is called Answers for Care, which I'm very excited about, to bring together a village of senior care solutions. It's going to be one site, one-stop shopping of curated, pre-screened, vetted professionals in the senior continuum. So if you haven't checked it out yet, if you're a professional, please take a look at Answers for, that's the number 4, care.com, and fill out the simple questionnaire so that we can see if you're a great fit for our village, as well as any of those that might be looking for different kinds of services. Please fill that out and answer those questions so that we can make sure that we bring all the professionals into the village that can suit your needs. And again, professionals that work in this field that I've worked with in the past that have been great service providers for the clients that I deal with. We would love to have you all here because together we really make a difference. So on that note, some fabulous professionals that we have here for our talk on Medicare 2025, and really buckle your seatbelts, everybody. But I'm going to start with introductions. So the first is Al Anastasi, who has been helping seniors with Medicare since 2017. He educates and guides seniors and other Medicare eligible people, helping them make the best choices for their individual circumstances. A senior himself, Al brings both personal and professional experience to the table and is able to provide the unbiased guidance that his clients want. Then we have Jane O'Malley, who has been doing Medicare for several years and enjoys working with the senior population. She's also a senior herself and is able to empathize with their concerns and frustrations, especially this past year. Medicare is a simple in its idea, but complicated in its process. And she's always encouraging people to reach out to a Medicare agent for assistance. There's no charge for what we do for any of these people on the panel. And we can prevent major mistakes, which is true. I've seen them do it for clients as well as family and friends. And then we have Stuart M. Small, who is an independent insurance broker specializing in life and health insurance with a focus on Medicare planning and employee group benefits. He represents many different insurance companies offering a wide range of coverage options to best meet their needs. Stuart's expertise and knowledge enable him to assist you with your insurance planning and be there consistently as your advocate and trusted resource. And I can say that, again, I've had the great benefit and luxury of working with all three of this crew. And as I said last time, we got the band back together again to really update us on the Medicare. And what I have for you on your screens is their contact information. I'll put it again when we finish. And for all of those that are here with us in real time, please put your questions in the chat. And after we're done, we can answer those questions. Okay, so we're going to start with what is Medicare, right? What is it exactly? And then we're going to talk about the different times we get Medicare, all of that information and when we can get Medicare and when's it time to look at Medicare. And then we're going to talk about different changes that have happened. So as a brief update that I like to do about kind of what's going on right now, as of April of 2024, approximately 67.3 million US adults are enrolled in Medicare coverage, according to Centers for Medicare and Medicaid Services, CMS. Approximately 50% of beneficiaries are enrolled in Medicare Advantage plan, while the remaining 49.6 are enrolled in Original Medicare. And then the other one, which I know we're going to be talking about, is prescription drug coverage remains a priority, as 80.4% of Medicare beneficiaries are enrolled in Medicare Part D prescription drug coverage plan. And as many of you hopefully know, and if you don't know, please share it with all, that it's so important to look over your coverage every single year. It's not a set it and forget it type of thing. If you're, again, fortunate enough to work with a great Medicare broker, they're doing their part. The ones that I know that are hardworking, getting that information out to you, giving you those reminders to open your mail and such. But you have to answer those questions. You have to get back to them. You have to open that mail. It's so, so very important. So we'll start off with what is Medicare, and we can go from there. I think we're starting with Jane, right?
Okay. Hi, good afternoon. Thank you for having me, Nicole. It's always a pleasure to be with you, and hopefully those that are on can share the information with your working partners. Medicare is set up for those people that are turning 65. It also is for people that are disabled and for those that are on dialysis. But for the most part, the majority of people is for when they're turning 65. So when do they make that decision about what to do and when to do it and how to do it? 3 months ahead of their birthday, they are able to contact Social Security basically and let them know that they are turning 65. And these are people that are not being covered by their employer, because that's another whole thing. But they would contact that. They would say, I'm signing up for Part A and for Part B. Part A is your hospitalization. So that covers anything to do with the hospital, as well as skilled nursing care, and as well as hospice care. The second part of that is Part B. Part B is the medical, and that takes care of your doctors, your laboratory, the labs, the blood work. And basically it's an 80-20. We all understand 80-20 in our coverage. So Medicare would pay 80%. You would be on the hook for 20%. So with these two parts, you still need another piece in order to cover you and have what we would call, suitable and comprehensive coverage, because 20%, if you're in the hospital, could be an enormous amount of money. So we always encourage you to get either a Medicare Advantage or Original Medicare. So that brings me to the two options that you have. Original Medicare is your Medicare card, A and B, which we just spoke about, your hospitalization and your medical. Then you would add a separate drug plan, which for any of you who are questioning, yes, it is required. Many people don't understand that. If they don't take drugs, I don't want to take a drug plan. Well, yes, you need it because later on down the road, you could be penalized severely. So yes, you would add a separate drug plan, and then you would add a supplement. And the current one in New York right now, or in this area that we're using, is the AARP supplement. And all doctors understand that. That was one of the original ones that started, and so they all know that. The second option that you have is the Medicare Advantage plan. Medicare Advantage plan is run by the particular carriers funded by the government. They are a combination of A and B and D all in one unit. There is nothing separate. Many of the plans are zero premium and, some copays. But the point of the Medicare Advantage plan that I want everybody to really remember is that you pay as you go. So instead of paying a premium for a supplement and a premium for your drug plan, you are now paying for services as you receive them. So it could be that you have, your primary care doctor, maybe that's a zero copay. You go to a specialist, maybe it's a $35 copay, $40 copay, whatever it is. You have an MRI, maybe that's $300. You have the point. It is a pay as you go for your services. And that's pretty much it as far as the basics go. Do you want me to expand on any of this, or this is kind of the beginning of putting A and B and D together? Where do you want to go from here, Nicole? I can't hear you. I'm sorry. You're muted.
You can keep going from A, B, I guess you did A, B, C, and D. If anybody has any questions about any of those, then we can move on to Stuart.
Yeah, I mean, I just don't want to take up anybody else's time because this is a pretty basic thing. I would encourage you to please get a broker, get somebody who can help you. Do not try to do it yourself. It is just too difficult. You will make mistakes. I can pretty much guarantee it. And then you're going to have a problem getting out of the mistakes you made. So try to get somebody who knows what they're talking about, who can help you get in the right plan. There is no charge for our services, as Nicole had stated. The insurance companies pay us, but we are the ones that have platforms available to us that we can see all the plans at one time. We can compare the plans for you, and we can help you get into a suitable, comprehensive and affordable plan.
Jane, there's one thing that you did mention that I often find that people confuse. So you said AARP. I find that oftentimes people think it's called AARP and it's not. It's United Healthcare. Is that the same one that you're talking about?
Yes, and people, will ask about that, but all they understand oftentimes is AARP because that's what they hear, that's what the doctors tell them. But yes, it is United Healthcare.
Okay. And there's other supplemental plans, but that's one of them.
There are several, but
accurate?
with the supplements, one thing that's very important with supplements, whatever supplement you choose, and they are according to letters, A and N and G and F and whatever. So whatever supplement that you choose, they're all basically the same. So if you have 6 companies selling supplements, they all have the exact same supplements. So if you want to buy an N plan, you could buy it from United Healthcare. You could buy it from Globe in New York. You could buy it from Humana. You could buy it from Mutual of Omaha. There are several companies that are selling them. However, it depends on who you buy it from as to what you're going to pay for the exact same thing. And right now, United Healthcare is the lowest price for the supplements.
Got it.
Does that make sense?
Yes, it absolutely does. Thank you very much.
Welcome.
And so, Stuart, you're going to inform us and give us some great information about all the other times we can potentially get insurance and Medicare, that is, and what that really means.
Hi, everybody. I guess what I really want to go over is I try to help people make sure that they don't make mistakes that could be costly or make assumptions they can't do something. And it turns out you should always ask, what do I do now? Life has changed. Can I make a change to my coverage? And what I really, first thing I go over, and I just got off the phone with somebody telling them, step one is you need to get Medicare Part A and B, as Jane outlined what those are. And a lot of people don't understand whether I do a Medicare Advantage plan or I stay with original Medicare, A and B, Either way, you first sign up for Part A and B. You can't jump ahead and say, I'm going to sign up for a Medicare Advantage plan. No, you got to get the Part A and B first. Then as life goes on, and this is what I really want to emphasize to everybody, is you can't make a terrible mistake or like a lifelong mistake is when you pick a plan. Once you enroll, whether you enroll in a Medicare Advantage plan or you keep original Medicare and fill the gap, we call it Medigap. It's a Medicare supplement, same thing. It fills in that 20% gap and so on. So whether you stay with original Medicare or you do Medicare Advantage, everyone gets the opportunity to switch that decision every January, which is like yesterday, open enrollment started till December 7th. So no matter what your situation is, any decision you make, think of it as, I can change it for next January. So it's not a lifetime decision. But what happens when life changes in between those dates? What if it's April or May and you say, gee, I wish there was a way I could change because I enrolled in, let's say, a Medicare Advantage plan, and now I realize it's not suitable for me. I really wish I could go back to original Medicare. So I don't want to get into every possible detail, but I'll give you just kind of a couple that pop up all the time. And the real point is, don't assume you can't do something. Call Al, call Jane, call me, and say, here's what's going on in my life. And the first thing I would answer normally is when someone says, I'm in the nursing home and they're limiting my ability to stay here for as long as my doctor and the facility and my family says I need, can I stay longer? And my Medicare Advantage plan keeps denying my coverage. They told me if I get back on original Medicare, that would be a good idea. So don't assume you can't. Call one of us and say, can I? So the answer is maybe you can. Maybe you can switch for the first of the next month. We have what's called SEP, special enrollment periods. And one of them happens to be I'm either in a nursing home or I was released from a nursing home. So either scenario, you actually can switch back, let's say, to original Medicare, using that as a special enrollment period. So it's possible. There are many others. We often ask about, do you have, in New York, do you have EPIC? EPIC is a SPAP, they call it, a state pharmaceutical assistance program. If you're a couple and your income is under 100,000, you can get EPIC. It's free, a free program. Helps with drug costs, but another benefit is it gives you one special enrollment period a year. So here we are in April or May, you want to switch, you can do it then, just because you want to. Maybe the drug plan you're enrolled in is not covering your drugs the way you'd like it. Guess what? You could change your drug plan. One time a year, I call it like a get out of jail free card if you've ever played Monopoly, so it's good to have in your back pocket. So there's some other special enrollment periods, typically when we leave employment. And I'm going to highlight things you have to watch out for is sometimes people, if you're still working, typically for a larger employer, and that just means 20 or more employees, really. So if I work for one of those employers, I like my coverage, I turn 65, I might only enroll in Medicare Part A, the hospital coverage, because I'm entitled to it. There's no cost, I'm entitled. I might not enroll in Part B because I like my employer coverage and I'm not required to, and I don't want to pay the monthly premium for Part B. I could wait till I retire. Well, now I'm going to be 70 years old and I'm going to retire now. At this time, you reach out to one of us for assistance. How do I add Part B later? There's a couple of forms to fill out. You fill one out, your employer fills one out to say, where have you been for the last 5 years, and then you bring it to Social Security office and they add the Part B. So don't assume what your neighbor did is what you have to do, because your situation may be different, where you could wait till later to add the Part B and stay on your employer plan. And beyond that, some employers have retiree plans, special plans. So us brokers, we always say, what other alternatives do you have? Sometimes if someone's retired for certain types of employers, they may be able to have coverage that most people don't have available to them. And we look to see what's the best option once you leave your employer plan there's pretty much no going back. So we have to make sure that whatever we're presenting to you is truly an improvement over what else is available to you. One of the biggest problems I've come into is someone leaves employment, let's say, they're over 65, now they leave the employment, but they want to stay on their employer coverage, go on COBRA, where you can continue employer coverage. It's the same coverage they had the day before they left employment. But guess what? They didn't have the Part B. They didn't need it because they were employed. But our government thinks that COBRA, it's a little different than active employee coverage. When you go on COBRA, instead of your employer plan being your primary coverage, it flips and becomes your secondary coverage, which means they say your employer plan says, we'll pay the 20% after Medicare pays their 80%. Well, guess what? I don't have Part B. Medicare is never going to pay the 80%. I'm in trouble. So I always emphasize to people, and a lot of people run into that trap, is when you leave employment, you could go on COBRA if you wanted to, but you must get the Part B immediately, or you could run into terrible problems with claims. The last thing I'm going to touch on is you're going to hear in the news sometimes, if I went back to original Medicare and I get a Medicare supplement, Medigap, to fill in the gaps, I want to do that. But I heard that you can't add a Medicare supplement if you're not healthy. You have to qualify medically. And we hear that. That is true in 46 states. So very important. In New York, we have guaranteed issue all the time, which means regardless of your age, regardless of your health, you could sign up for a Medicare supplement. They can't charge you extra and they can't decline you. So when I have folks that are going to move to one of the other 46 states from New York, I say, make sure you're on the plan you want to be on, because when you move to the Carolinas or even to New Jersey, you could take your plan with you, but you might not be able to get a Medicare supplement after you move. You might, because of your health. So I always emphasize to people, when I first enroll them, I say, if you ever are going to move out of New York, talk to us first to make sure that's going to not be an obstacle. So very important, New York guaranteed issue all the time, right? So that's important to know. Somebody just asked me, what are the other 3 states? Well, the rules could be slightly different in all the states. New York probably is the most liberal in this regard, but the other 3 states are Massachusetts, Maine, and New York. Connecticut. So those are your 4 states: New York, Connecticut, Massachusetts, and Maine. They might have slight variations on what they mean by guaranteed issue, but all of them basically, regardless of your health, you could get some sort of Medicare supplement plan in those states. I said I was only going to say one other thing, but I'm going to say one more other thing, which is a lot of folks, when they first go on Medicare and they go into a Medicare Advantage plan, which means an insurance company is paying your claims instead of the government. Let's say it turns out my doctors don't accept my Medicare Advantage plan, or I realize that, as Jane was talking about, you pay as you go, I realize my pay as I go is going to be very expensive because my health had a sudden, unexpected change. So can I go back and get a supplement? Or can I go back anytime I want? Everyone can go back the next January, right? But what if I want to go back in May? There's a rule, think of it as an exit ramp, which I always like to talk to people when they enroll. Here's what you're enrolling in and why you're doing it. Just in case, I want you to know your exit ramps, like the ones I mentioned to you, like Epic. Well, there's one other, which is the first 12 months, when you first sign up for Medicare Advantage for the first time, you can they call it like a trial period. So anytime in that first 12 months, you could just say, nah, changed my mind. I'm going back to original Medicare and going to get a supplement. You can do that in the first 12 months. No one can deny you that. They call it a trial period. And I've utilized that multiple times for those scenarios. And that's one that people generally don't know about, but it's there. So those are just some examples. But I think the real takeaway is talk to a broker like one of us. An independent broker represents all the carriers. Make sure that we're exploring all of your unique options based on your employment, your spouse's employment, et cetera, what you have available, and get the guidance. And when life changes, don't just assume because people say to you, you're kind of stuck, you have to wait till January. Reach out to, again, to an independent broker, and we can explore, is there a special enrollment period that you might be entitled to? I can't always guarantee everything's going to work for everyone all the time, but we have a whole menu of possible options to help you get what it is that you need and want. So hopefully that gave you an idea of just, I don't expect people to remember everything I said, but maybe a light bulb goes off when your friend tells you, I'm in a terrible situation and everyone says there's nothing I can do. You might say, well, maybe not, but maybe there is, and you should talk to someone before you give up on it. All right. So
That
with
was
that, that's
great,
all I have to
Stuart.
say. Okay.
That was excellent. And one of the things, and please comment if I have this incorrectly, but one of the things that help you make the right decision for you is to know your doctors, to know your medications, to know kind of your medical history and what's kind of going on with you. Because with that information, just like with being a patient of any kind, you are the best informant
Yeah.
of making the best decisions
Yeah.
for you, because we're all very, very different.
That's a great comment and something I mentioned to people. Sometimes they get nervous if they go into a Medicare Advantage plan. What if, suddenly I need expensive services, surgeries, rehab, et cetera, and suddenly a zero premium, people say zero, they think means free, and zero suddenly becomes very expensive. So one thing I say to people is the vast majority of our surgeries that lead to rehabs are not emergency surgeries. They're things like hip and knee replacements, things that we plan and avoid for as long as possible and eventually give in and do, right? So when you know that spine surgery is coming up, people don't run in to have spine surgery. They look at every other option and eventually they do it if they need to. If you realize that my Medicare Advantage plan may not be suitable because the surgeon I want to use doesn't participate, maybe I'll switch back to original Medicare for January 1. But guess what? I've been avoiding this for a year and a half, the surgery. So switch for it's a planned surgery, is my point. Switch for January 1, comes middle of January, you go have your surgery, your rehab, your surgery, your hospital, all could be at zero cost with your Medicare supplement in place. So and you can get to the surgeon that you wanted. So I tell people, plan ahead, think about this mid-year. Is life changing? And plan and make the change for January 1. If you have to do it off cycle, et cetera, then we have to look for those special enrollment periods. All right.
Right. Perfect. Thanks so much, Stuart. And Al, you're going to discuss with us all of the crazy changes that are happening and potentially how we can get help to navigate them.
Yes, I am. This is a very exciting year, unfortunately. There's a lot going on. Every year Medicare makes changes. For example, I'll just go back a couple of years in 2023. A couple of the things they did was they capped the cost of covered insulin products in Part D plan to $35, which helped a lot of people. They eliminated costs for recommended vaccines like shingles and pneumonia. For this last year, for this current year, 2024, a couple things the government did was they expanded the low-income subsidy or extra help program, so it covers more people and help them with their drug costs. And they also this is the first year where when someone reaches the catastrophic payment phase, and I'll go through payment phases a little bit without making it ridiculously detailed, but once they reach the catastrophic payment phase, there are more costs for their drugs. So that was a big change. And, so people said, well, when I get to the catastrophic phase, I don't have to pay anything for my drugs. That's right. But in 2024, the way you get there is much different than the way you're going to get there in 2025. All right. So currently, just a little bit of background. There's four payment phases. So when you have a drug plan, and most people in Medicare have drug plans. Some people don't because they opt out, or they have coverage through the VA or something like that, which Medicare counts that as being creditable. But most people have drug plans. So they go through a kind of a payment path, if you will, where the first phase would be deductible. Most drug plans, not all, but most drug plans have a deductible amount. And some of the drugs you take, especially if they're more expensive, will be subject to a deductible. So you need to pay off that deductible. And then when you've done that, you exit that phase and you go into the initial coverage phase where your drugs become less expensive, relatively, and you pay a smaller copay or co-insurance until you spent enough money and you graduate to what's called the coverage gap or the infamous donut hole. And everybody in Medicare knows what the donut hole is. And I'll talk a little bit more about that. And then after you're in the donut hole for a while, paying greatly enhanced, or not enhanced, but more expensive copays and coinsurance for your drugs, after you've paid enough, you go into yet another payment phase, which is catastrophic. And this year, in 2024, once you reach catastrophic, as I said, your drugs are free. Okay. When you're in the donut hole, though, there's a cost of 25% of the retail cost of the drug. And this can be very, very significant for people. Take, for example, a drug like Eliquis, which is a very popular blood thinner. It retails for about $600. So while people are in the donut hole, they're paying about $150 a month for that drug. And when they were in the previous phase, the initial coverage phase, they might have been paying 47. So now it comes, the typical scenario is the phone starts to ring in August, September, October. Al, how come my drug bill was so high? And it's because they entered the donut hole. All right. So to get out of the donut hole, it's very difficult. You have to spend upwards of about $8,000. It's a very complicated formula. It could be somewhere between 33 and 3,800, or could be up to $8,000, depending on your mix of generic and brand name drugs. But most people that enter the donut hole don't get out. It's kind of like the Bermuda Triangle, right? And it's very frustrating for people. And then the year ends, and they have to start again with their deductible. So it's a never-ending cycle for people, especially people that have expensive drugs. Well, in 2025, all of this is going to change, and what's going to happen is there's going to be a cap of $2,000 for out-of-pocket spending on prescription drugs, after which you'll go directly to the catastrophic phase, bypassing the donut hole because the donut hole has been eliminated. So the only thing standing in your way of getting free drugs is spending $2,000. That's not totally true. There is something else I'll talk about. But the $2,000 is a very enticing number for people, because they know that even if they're taking drugs that will cost tens of thousands of dollars, their out-of-pocket is going to be limited to $2,000. So eliminating the donut hole made it a lot easier for people to navigate the drug plans and a lot less expensive for them to get their drug. That helps because then more people will stay on their drug regimens, and that'll have positive health implications. All right. So it'll also, for people that uh, that uh, aren't going to get into catastrophic, they'll have more even co-payments across the year. They're not going to have that spike at the end of the year. A caveat, a little bit of small print with regard to all of this. The new spending cap of $2,000 does not include, it includes deductibles, co-pays, and co-insurance. So whatever you spend out of pocket on covered drug, the drug needs to be covered. If it's not on the plan's formulary, which is their list of drugs, it doesn't count towards the 2,000. So you need to be very diligent about making sure that all of your drugs covered, even if they were covered this year, they may not be covered next year. And I'll talk about that in a little bit in a minute. So that's very important to understand. Most of my clients are not going to reach the $2,000 catastrophic level. Some will, but not that many. But a lot of them are going to go into the donut hole. So they're not going to miss it when it's gone. And the reality of all of this is that it all sounds really good. It is good for a very small amount of people, but in order to provide this financial relief to relatively few people, costs are rising sharply for everyone. All right, premiums have risen. The premiums for the drug plans, which don't count towards the $2,000 limit, are going up astronomically. We've already seen many plans being canceled, drug plans, Medicare Advantage plans. Some of them are pulling expensive drugs out of their formularies, cutting back on some of their extra benefits. The industry has adopted, I guess the fashionable term in the industry is disruption. All right, there's a lot of disruption because everything is changing. And on one hand, certain things are going down. On the other hand, they're rising sharply. So that it's all we don't know how it's going to play out. I think Medicare is going to accomplish their goal of obviously lowering drug costs for a lot of people, but the law of unintended consequences is that they're going to raise costs for a lot of other people that just have normal drug costs.
Al, can you just go back for a little bit and just describe or give us the definition of premium versus deductible so that everybody can be on the same page of what's covered and not in that?
Absolutely. Okay. So when you buy a drug plan, you pay for the drug plan like any other insurance plan, and what you pay is your premium. So give you an example. I'm on a drug plan that costs $73 a month. Going to 108, but right now it costs $73 a month. All right. So that $73 is the premium. And again, that doesn't count towards the cost, the $2,000 limit next year, or whatever the limit is this year. Deductibles is what you pay. The drug companies want to make money up front, so they some less of them did this last year, this year, but almost all of them are going to have deductibles next year. So when you have a deductible and you have a drug that costs, say, $500 retail, what's going to happen is you need to pay the full price of that drug, that $600, before you have the privilege of paying a lower copay. So it's just like a deductible in a medical plan. Medicare, for instance, original Medicare has a $240 deductible where they don't start to pay their 80% until you clear that deductible. Okay, and then copays, that's the amount that after the deductible that you pay for your drug, or in the case of Part B, you pay for your service. It's a static amount that you take out of your wallet and you pay it. So a $20 copay, $40 copay, or whatever. Coinsurance is a percentage. And in drug plans, some of the drugs, depending on the tier that they're in, drug companies arrange their drugs in tiers so that they can charge a different amount for each drug. Depending on the tier you're in, you could pay 25%, you could pay 16% or 14% or whatever it might be. That's coinsurance.
And the
Okay,
co-insurance
so
does
when
go
you pay,
against the $2,000, correct or no?
as long as it's for a drug, right,
Right.
definitely.
Okay.
Okay.
Thank you.
So again, this disruption thing is really it's driving everyone crazy. People that are in the business, people that are getting into Medicare, and people that are already in Medicare. All right, so those are the major changes, but there's three others I have to talk about. They're a lot less exciting. One has to do with payment plan, where you can estimate the annual cost of your drugs and spread that payment out across 12 months. I don't know yet. I don't know if anybody else knows exactly how this is going to work. It's being talked about a lot. But if you use the example of somebody that's going to make the $2,000 cap, and you divide that by 12, they can make payments of $167 and change across 12 months and pay for their drugs. They no longer have to have that deductible where they have to pay maybe $500, $600, $700 between January and February before their drug prices normalize. So I think this is going to be initiated by the carriers. I don't think that brokers are going to get involved with this, but I just don't know yet. We'll have to see how it plays out.
Al?
Another thing, again,
Yeah, from what I'm understanding, if somebody is at the drug counter picking up their drugs and it's like $500, $600, and they go, well, I can't pay it, the druggist, the pharmacy, will contact the carrier, and the carrier will take it from there in sending the bill.
okay, that's interesting. I heard that as well, but I asked the guy at my drugstore about it, and he had no idea what I was talking about. So
Yeah.
it's not
They'll find
really
out.
out there yet.
Primarily, that's going to be directly with your insurance plan and the subscriber.
Mhm.
I called an
Mhm.
insurance company yesterday just for the general question, and one of the prompts immediately was, do you want to hear about the premium payment program? And really what it is
Oh.
just a way to spread out a large expense over multiple months. They're trying to make it easier.
Exactly.
Yeah. So,
Right.
but it's going to be, you're just going to call up your carrier and they'll set it up. It's an interest-free payment program. So if somebody had to pay that whole $2,000 in month one because they had a really expensive drug, if they preferred, they could pay the $2,000 over a 12-month period, as opposed to just
Right.
paying it all in one lump sum. And that's between you and the
I think
insurance
it's a good
company.
thing.
Well, we'll see. We'll see how it
Yeah.
plays out. But they're trying to help people with that. Yeah. And I don't want to be involved in that as a broker. It's the carriers are going to handle that. So we trust them for that.
No way. So thanks for that, guys. The last two things. There's going to be some potential expanded coverage of weight loss drugs in Medicare in 2025. Medicare currently does not pay for weight loss drugs, but they may if the need for weight loss is associated with cardiovascular disease. Certain of these drugs, like one very well-known drug, Wegovy, I don't know what the other ones are, have been approved for use for weight loss to treat cardiovascular disease. Now, that doesn't mean that all plans are going to take up and cover these drugs. If you need to take these drugs, you better choose your drug plan carefully. I think that maybe in 2026, it'll be a little more clear. It's exactly what's happening, and this trend will start to play out. These drugs, if they are approved, are going to be uber expensive, but the saving grace is that you still have the $2,000 maximum as long as the drug is covered by your plan. All right. So that's all good. And then last on my list, and this is something that's been coming and talked about for a long time, and we'll see how it goes. But there's going to be a push to add more licensed mental and behavioral health providers to Medicare. Right now, they can't bill Medicare. The credentialing and certification process is very lengthy and detailed, so it's going to take time for these people to get on board. But once they do, it's a sorely needed area that Medicare needs to address, and they're going to try and start doing it this year. So that's all I have. Anybody have anything that I missed?
That was great, Al. I think you covered that. I see a question here, and I'm going to bring it back to Jane or Stuart. It's could someone please clarify, a person who is working and will enroll in Medicare at their 65th birthday, should they enroll in Medicare A and B or just Part A? I know we covered this, but it's good to go over again.
Yeah.
Right. I think Stuart had said about that. It depends on the size of the company, number one. So, and it depends on whether they're going to go on to COBRA. Both of those things would require A and B.
Yeah, I do a lot of employee group benefits, businesses, and a lot of my Medicare are people who are transitioning, who call me because, that situation. So I think, Tim, that was your question, right?
Mm-hmm.
Right. So the answer is, I'll give you the official answer, is generally speaking, everybody should enroll in Part A when they turn 65 because you're entitled to it and there's going to be no cost.
Right.
That's the general answer. Part B depends on the coverage you have through your employer. First of all, do you like it and want to stay on it? And if you do want to stay on it and it's favorable, you need to know, will your insurance be considered primary? And I'm clarifying it because this comes up a lot now. You might have a group that has only 15 employees. So my general thing would be, you got to get Part B, but there are some exceptions. Some of those groups might be through what's called a PEO, a professional employer organization, like you might hear about a JustWorks or an ADP Total Source, where you're really treated as a large employer, even though you only have 15 employees. So I get those questions all the time. Somebody says they have whatever they have, Aetna, whatever, through their employer, and they only have 14 employees. I tell them, go back and check with your HR person. And it turns out they do have the Aetna through CoAdvantage. It's a PEO. I just had one the other day. They said, no, you don't have to add Part B until you retire. So that's why it's very important to talk to one of us, and I tell them what questions to ask and when they go back to their HR department, because there are exceptions. But here's the one important thing I would say is sometimes you might be in a larger group or not having to add Part B. Why not take Part A? It's free. Makes sense, right? There is one important exception to that, which is if you're on a high deductible health plan and you're making contributions to a health savings account, which is very, very common now. People have those kinds of plans and they like putting money in a health savings account because you get a tax deduction. Well, if you accept the Part A, premium-free Part A, The government says you cannot make a tax deductible contribution to a health savings account. So that's the one caveat. So that's why I say be a little careful there. The easy thing is just sign up for Part A and B Medicare when you turn 65, nice, easy. But what if you want to, if you're still employed and everything, discuss it with someone like us, because I may not give you an immediate answer. I'll give you guidelines, but I'll tell you the questions to ask your employer. And sort of the summation of the questions is basically I tell people, ask your employer, are you going to treat me any differently the day after I turn 65 than the day before I turn 65? Does anything happen to me on this employer group plan that I should know about? And your question could be that simple to get the HR people to really guide you to not make a mistake. All right. Because, you know, they're not always paying attention to your age there. All right.
Yeah, that's a really good answer. And it's a really good question, because one of the things that is true that I find with my clients and friends and family as well, they go to their HR department. The HR department has no idea what they're talking about.
Correct.
So it's so important to get that information. And if you feel, don't put all your eggs in their knowledge basket.
Mhm.
So reach out to somebody like a Medicare broker to say, okay, this is what I have. And they might not have the answer because they're not going to know every employment plan that's out there. But then you can call the insurance company
Yeah.
yourself and find out those
Right.
answers, because there's been so many times when people have contacted me and their HR department or the person that's supposed to know told them something completely different. So
Correct.
always check
Yeah.
and then
Mhm.
double check and then get it.
That just happened last week. Yeah, and I mean, I had a client and she said, and I asked her those same questions. She came back, there's 21 employees. I went, that's a little bit on the fence. And we decided, you know what, call the company that's covering you now. She asked the question. They said, nope, we're not going to cover you. She had to get Part B.
Yep.
So
Yep.
the
Yeah.
20 could be, 21.
A close 20 is tricky because
Yeah.
they're not, it's not 20 today. They're using a 12-month measurement period and an
Right.
average of 20 over the 12-month average. And
Yeah.
you know, sometimes numbers change. And importantly, even if you have 20 or more, let's say Oxford, the insurance carrier, whoever it happens to be, do they know that you have over 20? Because you might only have 7 enrolled in the Oxford
That's
plan.
enrolled. Yeah.
And Oxford doesn't realize that you have 24 employees. So you got to actually make sure they have it in this system flagged. Otherwise, they're going to say, we're not going to pay your claims. We're going to wait for Medicare. So I always go back to the carrier to make sure they actually have it in their system that they are primary payer. It might be just letting them know and having them update their system.
Absolutely. That was a great question.
Yeah.
Do we have any other questions, or our fabulous panelists? Do you have any last words or tidbits that people should take away? I don't have any questions in
Just
here.
reach out to us,
Exactly.
or I always say, or someone like us, and find an independent insurance broker who you know and trust, who's been referred
Right.
to you in some way, and ask questions.
Exactly. These are great brokers, and maybe you don't even live in this state, and they may be able to help you anyway, the brokers that are on here right now. But oftentimes people come to me and they think that somebody's an independent broker and they're not. So that's a really good question if you're going outside of the village, if you will, to find somebody, because it's not, I don't think they're trying to lie, but people just think that, oh, well, I'm on United Healthcare and this person said he or she is my broker, because they're only a broker for that plan, for United Healthcare. So, or for whatever insurance they work for. So it's really important to find an independent one. And again, I've heard that some they're calling themselves independent, but are charging. And who knows what tomorrow brings, but ask that up front. Ask if they charge for any of their services.
And
Okay.
independent brokers do have, just so that everybody understands, we not only have to be licensed in whatever state that we represent, we also have to be certified with every single carrier that we represent.
Right.
Mhm.
So, well, thank you very much again, team, for giving this valuable information. And thank you, all of you that came and participated and were here with us, for adding your insight and questions. And we'll see you next time when Care Answers webinar in November.
Thank you.
Take care,
Nicole.
Thank
everybody.
you, Nicole.
Okay, bye-bye.
Thank you so much, everyone.
Thank you.
Thank you.